I had, I had to sell homes in that, and I got treated like a transaction that wasn't nice, and they didn't help, and, it was like basically press here, sign hard, press here, stick a sign in the yard and let me know when it's ready. And so that's why I got my real estate license, because I wanted to help people. And then in the course of helping a lot of people through probate, I realized there wasn't a whole lot I could do after the person was dead. So, devastated family, there's nothing you could do to fix that, right? We needed to start ahead. So I went back to school, I got more education, and I'm now a certified senior housing professional, which means I look at the totality of someone's situation and what they want to do, whether they want to stay in their home, or they want to move to a community, or they want to downsize to a smaller house. We look at the whole thing, and we figure out a plan on what you want to do, because it's your choice. And right now, while you're walking, talking, smiling, and able to do things, you have the full luxury of your choice. If something happens to you and you go to the hospital, even if you're still kind of with it, your choices start dwindling. And that's why I am doing these things, because I want you to be informed. I want you to know what your options are, and I want you to make choices and plan now, so that if, God forbid, something happens, it's just like insurance, right? We've got a plan in place. We know how to handle that. We can do it. I've seen too many people try to keep their pride about them and not make a choice, and they're teetering on the verge of incapacity, and the family's over here talking about guardianship and getting them deemed incompetent because they're becoming dangerous, right? They're still trying to drive their car. They're still trying to do things. So, for me, looking at it from a 30,000-foot view, there's so many things that should be in place that at the last minute we're scrambling, trying to get power of attorney, trying to get things so that this person will continue to be safe and live quality of life, even when they can't make those decisions. So, anyways, enough about all that. I have a great panel today. I always bring in good people. I've met them, I've worked with them, and they are in-home health care providers. We're gonna talk today about, it's more of a conversation. We're gonna talk more about the myths, things that you've heard rumbling around, your friends say, things that you might think might be true, but we're gonna dispel the myths, and we're gonna find out what the actual truth is, okay? So we first have Stephanie. I'll let everyone introduce themselves.
I'm Stephanie Watson. I'm Regional Director for Pinnacle Home Care. I'm a licensed physical therapist assistant as well. I've done home health as clinically for 15 years before I moved into the business side of things. But it's one of my great loves is home health.
Good morning, I'm Herb Selden, and a little more than 12 years ago, my wife and I opened Visiting Angels in Palm Beach Gardens. About over 88% of seniors prefer to remain in their own homes as they face the problems of aging. And our primary mission is to give them the support services to enable them to do that. Prior to opening Visiting Angels, I spent about 15 years working in assisted living, actually well before it had a name. So I'm familiar with both solutions to the challenges of aging.
Good morning, I'm Laura Dwelly. I am a registered nurse and certified dementia practitioner. I have a business called LM Services, where I specialize in providing care management services, patient advocacy, and as Sean was mentioning earlier, helping folks who have made those decisions put the decisions in place, setting up home health agencies, additional services, providers in the home, equipment, and helping to navigate the complex healthcare system that we find ourselves in today.
Good morning, my name is Michelle Truman. I am an autonomous nurse practitioner. I have a house calls practice in Palm Beach County, servicing only northern Palm Beach County. I started this practice 10 years ago, before it became kind of trendy to do house calls. I have been a hospitalist nurse and a hospice nurse practitioner, and so I have seen the need for services to be delivered in the home. and what that means to patient care when they are. I do my own nurse practitioner role, and I do my own blood draws. I'm kind of a one-man band. I have a very small practice, and I keep it very personalized. That's about it.
So the idea here is we brought in people, different levels, different sizes of companies, you know, some that handle Medicare stuff, some that are more, you know, private, personal, so, you know, because everyone's different. So we're gonna hear from different people. But I think the one thing I wanna get clear is we talk about in-home health and in-home care. What's the difference between that? Who wants to take that?
So with skilled care is what Pinnacle provides. So we're your Medicare certified home health agency. We provide skilled care. So skilled care being a skilled nursing, RN, LPNs in the home. We provide skilled physical therapy, occupational therapists, speech therapists, medical social workers if needed in the home. So, and they will determine the frequency of visits. So they're not gonna be in your home every day. It might be a couple times a week, depending on the need and the skill needed. If you're looking for somebody to kind of do more of your house chores, more being there for extended hour periods, errands and things like that, that would be your private duty, like visiting angels, and you can explain more.
Okay. That's accurate, Stephanie. We do what can be called assistance with activities of daily living, the things that a person needs to have help with throughout the day, as opposed to an episodic visit where somebody comes in and gives an injection or something like that. So we help with things like dressing, bathing, grooming, medication reminders, errands, like housekeeping, trips to the doctor's or physical therapist's offices, and just a whole panoply of services, and we tailor them to meet the needs of the client at a particular time. If medical issues become more important, we work with a company such as Pinnacle to bring in those more skilled services.
I'd like to add that in-home care is basically anything you want it to be. You can have massage therapy, wound care, you can have dialysis in your home. There are so many services that are available as in-home care. And Pinnacle is of a company that deals with insurance reimbursed care, and IRV deals with a company that is private duty care. And then Michelle and I work in the field providing the care. I can do whatever nursing care that needs to be accomplished in the home, whether it's just vital sign monitoring and reporting back to your primary care, performing some wound care, you know, minor wound care preferably. I can do a lot of treatments in the home, medications, for instance, nebulizer treatments, IV therapies and things like that, but also attending doctor's appointments with patients, setting up pill boxes, monitoring pill boxes and medication management, and then working with providers for in-home services, like Michelle's.
I think the easiest way to describe my role in the mix is if you go back to 1940s medicine, when the doctor came with his little black bag, which I literally have. I look like a flight attendant carrying my bag into your house. I'm the doctor with the bag that comes along, but so that's, I like to differentiate what my practice is as a house calls practice versus home health, because I would come in, evaluate, do an exam, pretty much anything that is done in a doctor's office, I can have delivered to your home, including EKGs, chest x-rays, ultrasounds, echocardiograms. I work in conjunction with a mobile imaging company who's been very responsive and wonderful to work with. I can bring IV therapy into the home. I have several IV therapists that I work with. And if there is a need for physical therapy through a skilled company like Pinnacle, I would order the physical therapy to be done and, kind of, I guess, kind of the quarterback for the team of people that, you know, deliver the care. But all equal spokes on the wheel, for sure. It takes a village, for sure.
So here's probably the most important question people are wondering is how does this get paid for and what can they expect to pay for in-home care? What should they be budgeting?
So for a company like Pinnacle Home Health, we are medically, use Medicare and other insurance, so some of your Medicare Advantage plans we accept, so they pay for the visits provided. And one of the deeming, I guess, needs is for you to be considered homebound, right? Homebound doesn't mean that you can't leave your home. You're allowed to go to doctor's visits. That means you have to drive yourself to doctor's visits. You can go have your hair done. You can go to church. It's anything that's a extraordinary tasking, physically or mental effort for you to leave your home will qualify you as homebound. So, and then that allow you to use your insurance benefits for the skilled care at home. So most insurance we do accept at Pinnacle Home Care. Some of your Medicare Advantage plans do have authorizations that are needed, so they only may allow a certain amount of visits to begin with, and then we have to provide them with documentation showing your progress and whether there's still a continued need for you to have the home health. Straight Medicare usually is, and there's no end limit when it comes to straight Medicare. As long as you're showing progress and there's progress made in home, whether that's with physical therapy or, you know, nursing, if you have a wound that we're taking care of, if you're needing IV therapies at home, that type of thing would deem you to have home health care.
In contrast to the third-party payment through Medicare and similar programs, in private care, the payment is either from private funds or if you're fortunate enough to have long-term care insurance, that pays for it. Probably about just over 40% of our clients are paid for through long-term care insurance.
So my services are totally out of pocket, but they're worth it.
I'll vouch for that. Yeah, Laura's extraordinary. I have a concierge practice. I charge my membership fee is $1,800 a year. After that, it operates as any brick and mortar clinic-based practice where I bill Medicare just like as if you would go to a doctor's office. There's no extra fee additionally to that for me coming to your house or transportation fee or anything like that.
And are there any like glaring things that people need to know before they embark on hiring someone? We might get to it in our myths and truths. Alright, so let's get to that. So, our first myth. How many of you have heard this? Oh, I'll be fine. I'll just have my friends help me or my kids help me. Who's thinking about doing that?
No.
I'll tell you what, they don't wanna do it. It's hard. Eddie? Yeah, so the actual truth is, extended care, it can be a taxing thing, and if anyone has an example, maybe you wanna.
I'm frequently more concerned about my caregivers than my patients.
Yeah.
After a very short period of time. Patients they're stabilized, they're doing all right. The caregivers look like they've been hit by a Mack truck, and they're stressed and worn out and don't have any time for themselves to fill their own tanks. So
Yeah.
it's fine for a short period of time, but it's hard. Yeah, it's overwhelming.
And I would say that a lot of what our clinicians do in the home too is a lot of education to the caregivers is a big part of it as well. Because we're not going to be there with the patient forever. So we need to make sure that the patient, not only the patient, but the caregiver knows parameters and has that, healthy living plan to continue in the home after we're gone.
Yeah. Well, there's other things too, like Herb
I
has.
just want to say, I think that there are some important emotional and psychological dynamics that are involved in accepting care. First is, I think that admitting that you need help is kind of a threat to your self-esteem. So we often see resistance that's based on that. It's particularly true of men who you know, they want to see themselves as macho and they can do everything. So that's one of the barriers to accepting care. The other is financial concern. People are often afraid they're going to deplete their estate that they can leave to their children. And another is guilt. Guilt's a big player here. And guilt really affects the family caregiver more than it affects the recipient of the care. So family caregivers will often not want to bring in additional help because they feel guilty. They feel, oh, it's my responsibility to take care of mom, okay? And I failed as a daughter or as a son to take care of my parent if I'm not doing the care myself. And what happens is, it changes the relationship. And instead of being a daughter or a son, you become a caregiver, and that impairs your family relationship and it burns you out. This is a terrible statistic to cite, but many times the caregiver predeceases the person receiving the care. And that's particularly true in cases where there's a long-term disease like dementia, and the toll it takes on the family is really dramatic. So that's what I have to say.
Yeah, and the other piece of it too is the patient, they're losing control of everything, right? So what are they gonna naturally try to do? Try to maintain control of any little thing they can, and that could be you saying, this is in your best interest. Oh no, I'm they're standing their ground. So, getting some counseling or understanding how to speak with them is also helpful to kind of make those inroads to communicate. And then also with dementia too, there's a whole different level of that, which we're gonna cover in June.
So,
All right, so the next one, how do you like the curtains? You like
Like
it?
that.
That's cute.
Yeah.
All right, so all licensed companies do the same thing the same way. You think that's true?
No, obviously.
Right.
Well, to add to that, even in our home health situation, it's always patient's choice to choose what company you would like to provide services for you in the home. And in Palm Beach alone, we have probably over 200 licensed Medicare home health agencies in just Palm Beach County itself. So really knowing or knowing somebody else who may have had home health that they could recommend is always kind of a good way to go. So just a little about Pinnacle, we are privately owned. We're actually the largest privately owned home health company still in the state of Florida. And we can follow patients from one side of the state to another side of the state and just transfer you to different branches. But just knowing that it is your choice of who you want in your home, and you have, that value. I always say reach out to somebody if you've never had home health before. Maybe somebody else, a neighbor, had home health that could give recommendations, because there's quite a few agencies out there.
Yeah.
Mm-hmm.
Yeah, I think there's just as many of those as there are realtors. All right, so our
I have
next.
a question.
Yeah.
Let's say you're, 6 months and 1 day in one state and 6 months less in another state. Does that hurt your insurance going back and forth, or is it easy to set up for somebody who's ill here? Like maybe your spouse is ill, and so that all transfers here pretty easily?
Correct. We usually don't have a problem. We have quite a few patients that we see that they're snowbirds that live, in the north and come down, for the winters and stay and maybe get sick and end up in the hospital. So it's just, the main thing is getting that order from a physician that's here in the state. Sometimes we do have patients that are out of state and have surgery and then come down here to heal and mend. We just send out one of our mobile physicians out to see the patient. They will see you and they will write us the orders, and then we can come out and see you. So,
Okay.
but
Laura is excellent at that, but, on that note, Laura and I had a couple of clients last season who transferred, and she was wonderful at pulling together specialists, making sure the records got to, transferred in a timely manner, making sure that there was seamless home care setup, and that the nursing assistants actually caring for the patients were communicating with the ones up north, and family was involved in multiple conversations, and it really helps to have someone like her in your corner to kind of bring all of that together.
Yeah, and
Thank you.
also to know what you need, right? Because, like even if you go to the ER, you go in and you don't have your list of medications, you don't have anything,
Right.
you don't know what papers to bring, you don't know what paper you need to get admitted to an assisted living. Someone like that understands how to get all that done. And if any of your snowbirds have that with you, which if you weren't here last time, I had those little file of lives, you can get that from me. That first responders know to get that off your refrigerator, and they will take that to the ER. Because they need to know, and don't think they can just call that hospital and get it. It could be 6 hours if they even reach anybody to find out what procedure you had. Okay, so to have all that listed is so helpful.
And the last thing you're gonna wanna be doing if you're a patient going into the ER, or even a stressed family member caregiver, is to have to repeat this to 3 different people on admission. It gets exhausting, and
Or you might not even know.
you might not know, you might
Yeah.
forget, and it's nice to have all this ahead of time.
Yeah, and especially the snowbirds coming who've had the procedure,
Yeah.
and they come here and they brought nothing. Not their care routine, anything.
On that note, I also learned from a neighbor of mine who went frequently to pack a little suitcase.
Bad idea.
Oh, that's a good
And
one.
have
Bad
it,
idea.
I mean,
That's a
you
great
don't wanna
idea.
think you're going, but you might.
It's almost like being
And-
pregnant again. Only on the other end of the spectrum.
And these are hard things to think about, but it's gonna serve you when you get there, so.
Yeah.
Yes,
that's a
Marla.
good idea.
Sean, does this mean that, for example, if we're sort of registered with somebody and we go to the ER suddenly, that they can go to our home and get the information and then cover us when we're in the hospital? Because I'm alone, I have no children, I have no close friends.
We should talk.
Yeah. What do you mean when you're registered, Merle? Like
We're
registered?
registered with one of these ladies.
Oh, yeah, so
Or
they, yes,
gentlemen.
yes, they can help you with that, yes, for sure. And it's a good thing to have, but you always call me too.
Huh?
Keeping the curtain.
I know. Okay, so, I'm required to use the company recommended by a doctor or nurse.
No.
No, we can choose whoever we want, and so if you go in the hospital, you can pick anybody.
I'd like to add, I worked in a hospital setting in case management. In case management versus care management, the goal is to get patients out of the hospital safely, but out. That's the primary goal. And oftentimes, I didn't know this, doctors have a vested interest in some home health agencies. So if you're being referred to a home health agency, it may not be because that's the home health agency that will help you the best. It might be for a different reason.
And on a similar note, if you are with a home health agency and it's determined that you need to go into the hospital, they are going to follow you in the hospital. That doesn't mean that you are married to them forever. You can decide in the hospital, I wasn't real happy with it. There must be a better agency out there for me that I may get more out of.
That relates to what I was gonna ask is, are there contracts involved? Now, there would be with a yearly concierge service.
Yes, but I'll tell you for my service, it's, if you decide at any point in the year, this is not a relationship you wanna continue, your prorated refund is given to you.
Cause, sometimes,
I
just as you're
stand by my
interviewing
practice,
services,
yeah.
whatever,
Yeah,
you say
I
this
stand
is
by
great.
it.
And then the person that's coming to your house, there's
Yeah.
just a personality conflict or
Yeah.
lack of communication, or
I
she
also,
always wears blue.
for my practice, I also, encourage probably 95% of the time, patients accept this appointment with me. It's a free of charge 30-minute meet and greet, I call it, that you do not pay anything for. I come over to your home because it's just as important to me that we have a good dynamic going on and a good rapport.
Can you please explain what happens after the $1,800 a year? You said something and I didn't get the whole thing about insurance.
Right.
Then, do you file insurance? It may be covered dependent upon
Not the
insurance.
$1,800.
So the $1,800 is like a membership
Yes,
to the
correct.
practice for me
It's not covered.
to basically I'm on call all the time for you. And when you call my practice, you get me. You don't get, go to the ER, you don't get an Espanol, you don't get a screen, an answering service of any kind. What I do with billing is I bill as, just as any brick and mortar practice does.
You bill the patient.
I bill the insurance
Oh, you
company.
bill the insurance.
Absolutely,
That's
yeah.
right.
I don't take HMOs. My practice
You don't
does
take what?
HMOs,
Ah,
but I
okay.
do take
Yeah.
I do take
Yeah,
private
I-
PPOs in network and.
But then if
Medicare.
you bill and if it's covered or it's, I know how Medicare pays,
Yes.
that was my business.
Uh-huh.
But, then you will balance bill the patient.
So for co-pays, are you talking about
Yeah,
co-pays?
and deductibles or whatever.
Yeah,
might
the
be.
deductibles I can't do anything about.
Yeah, no,
You know,
of course
but as far as co-pays go, my biller hands me my list, my co-pays bills that she's getting ready to send out.
And you bill.
And I decide if I wanna bill or not.
Well, with
I usually
with
write off phone
Medicare, you
calls
have
and
to
that kind
bill.
of things.
With Medicare, you have to at least attempt to collect or else you lose your participation in
I
Medicare.
do, yeah.
Yeah, you have to at least show that.
That's why I have a biller.
Yeah.
That's why. Anyway, we're
Okay,
going off.
but you don't do HMOs,
Yes,
okay.
sorry.
All right, next myth. Okay, so home health and personal in-home care can't be used in a retirement community setting.
Oh.
What do you think?
We have a number of clients in assisted living, we have a number of clients in independent living, where we're supplementing the care that's given by the staff of those facilities. We also, have caregivers who go into the hospital or the rehab to provide additional assistance for our clients.
One of the most important things that I can do for family members who live out of state and have a loved one here who ends up in a hospital or in a nursing home or any level of care is to go in person when they're not able to do so and report back how that client is doing, whether they have wounds, whether I feel like there might be an issue in the facility. It's all very professional. I'm able to call in nurses and say, look, I'm really concerned about the weight loss. Could we maybe do some nutritional supplements? But having eyes on a person in a facility is incredibly important
Yes.
for family members that need to know what's going on.
Absolutely.
And also for that the workers there to know that someone's watching.
Mhm.
Yes.
Cause
Makes it
I know, and you know too, Claudette, if they know that certain people aren't being watched and the ones with the family around, they get a different level of care.
I was an ombudsman for 10 years
Yeah,
in long-term
so
care, so
it
I
happens.
know. Sometimes my frustration would be either with the patient, with the family, or with ACA, or the administration, so it was quite a job to get everybody on board.
But this is how we help prevent that. We know ahead of time that could happen, so we're gonna, knowledge is power, okay? Okay, let's see, our next myth. So in-home care services are only appropriate after a hospital stay. No, you can get it, if, for anything, right? And like some of you were saying, you have preventative services and things that, even if you're like starting a new medication or something, or you just need help. Asking for help is your superpower, just remember that, okay? Any questions around that? This is a good one. I can save money by hiring a caregiver outside an agency.
I've heard people say that.
Yeah. Have you ever heard that thing, you get what you pay for?
Yeah, you don't get it now, you don't pay
Yeah,
it later.
we've got a lot of insurance issues.
Right, so this is something I'll let you all address, but, you know, hiring outside individuals, there's a lot, remember our last session, we learned a lot about that, right? They need to have, most importantly, insurance. Cause who's gonna be liable if something happens to them? You. You know?
I can
Herm?
address this. You know, over the last decade, I've seen just about every bad scenario you can imagine. There are two kinds of home care companies licensed in Florida. One is an agency, which is what we are, and an agency is employee-based, so the caregivers are direct employees. We cover your workers' compensation, we withhold your taxes, they're bonded, they're background checked, and there's all sorts of verification processes. The other licensed type of care is called a registry, and that is really basically a referral service. The caregivers are independent contractors, and the company, the registry, is not even permitted under Florida law to supervise or oversee them. So there's very little accountability with a registry. The third unlicensed component are what we call gypsy caregivers. And these are people who, they may be wonderful caregivers, and there are some, but in terms of the risk that you're taking, there are so many risks. Unless you can do your own background checks, and that's very difficult and filled with all sorts of liability issues, you really don't know what the background of this person is. The second is if you don't pay their taxes, you can end up being responsible for their taxes if they don't report and wholly pay their taxes. And third, if you hire Mary and you think she's wonderful and she's caring for you on a regular basis, if Mary gets sick and you really need to have somebody there, there's no backup. Whereas if you go with a licensed agency, there's somebody who can be sent right away to fill in if Mary is ill.
That's good, that's good info. Yeah. All right, so we're already at the Q&A. Elisa?
I have a question for Irv. How much does it cost for home health services, like a home health aide to come in and help in a home?
Okay, so for private care,
Yeah.
the average in Florida is about $28 per hour.
Okay.
That includes registries and agencies, and registries, because they're not paying taxes or workers' comp, are charging less. The average cost for an agency is $30 to $33 an hour. And then there are complexities to the pricing as well. If you get 24/7 care, the price can be reduced because of the number of hours. If you get just a short amount of care, like 2 hours or 3 hours or 4 hours, the cost goes up because the caregiver has to be paid more to go for just a short visit. Because if they go for 2 or 3 hours, they could be giving up the opportunity to go for 8 or 10 or 12 hours somewhere else.
So one thing that I just wanted to bring up with Medicare, so how many of you got this? Who read it?
No.
But this is everything you get,
It's in
like,
files
why
somewhere.
not?
I read it.
So, I mean, I just had this, my friend just like gave it to me, I don't qualify yet. So she gave it to me, she's like, I don't even know what that thing is, there's so much in there, so.
Is that Medicare?
Yeah, it is, the Medicare book.
Yeah, Medicare book.
Yeah, but using someone like this, this is what they do every day, so, you know, these are things that you're entitled to have. So my gosh, it'd be so smart to use someone who knows how to get you the benefits that you're entitled to, cause I'm not reading this thing. What else, what other questions do you have? We're early today.
Oh, okay.
Yeah. Well, someone had mentioned on the last survey that they thought an hour and a half was too long, so, yes, Diane.
So back to the discussion about a registry versus an agency. Could you tell me, like, say you hire a registry and the caregiver hurts their back moving someone, and it turns out to be a big problem, and there's all kinds of medical expenses, and what happens then? How does that work, like, as far as lawsuits, I guess?
In the case of registry,
Yeah, if someone's,
there's no workers' compensation insurance, so if the caregiver injures herself, you're talking about a caregiver injuring themselves in the home?
Yes, yes.
So you get sued.
Yeah.
Oh,
And
there you go.
there are companies out there that, you know, kind of specialize in
Yeah.
representing caregivers who get injured in people's homes. So, you may have, your own private insurance may cover that,
Uh-huh,
but you're basically, you're unprotected.
right. Whereas if it's a, agency like yours,
If it's
you
an
have the
agency,
whole agency backup for us.
yes, it's covered by workers' compensation, which
Right.
is a very highly regulated program.
Right.
yeah. Alyssa, did you have a question?
Oh, do any of your agencies here work with hospice programs?
So with skilled home health, actually, if you decide to go with hospice, we are not able to provide the care.
I work closely with hospice patients. Only because I used to work for hospice for 2 years. I've found out that a lot of the providers will basically pull out. If you've had a doctor in place doing your primary care for 20 or 30 years, as soon as you go on hospice, they pull out. And it's the hospice doctor that runs the show. I don't do that. I stay very much involved until the very end with my patients. And I've developed a nice working relationship with both VITAS and hospice of Palm Beach County, or Trustbridge now, I guess, so.
We work with hospice all the time.
I thought with hospice, because I also worked at hospice, for some diagnosis not related to the diagnosis that has entered you into hospice, you can still see your
Yeah, so
doctor treating you for that.
that is that small
Yeah,
little
I know,
niche
yeah.
window
Yeah.
that
They
physical
choose to.
therapy
Yeah.
could still go out and be paid, you know, under that, if it was a different diagnosis from what the deemed diagnosis is, why they're seeing hospice. You know, sometimes it's hard to have those situations, right? But there is small, and also patients come off hospice.
Right.
And then we see them again, so maybe they started with a skilled home health company, and they move into hospice, and then they see a progression, they come off hospice, and they're back to home health again.
But there are various ways to receive hospice. Let's say you're in your home and you're receiving hospice care for cancer.
Correct.
But you have a cardiologist who's treating you for a heart condition. Are you not then able to see, I believe, you can see that cardiologist if they don't pull out?
Yeah, oh yeah,
Yeah,
absolutely.
I mean, yeah.
I have a question for you all. When you hear the term hospice, how many of you kind of cringe and don't want to have anything to do with it?
I've had a lot to do with it.
Alright, so we might have experience with other family members, and I think it's important for every one of us to have an idea of what we want for ourselves in the end, not necessarily the last few days, but towards the end of our life. How do we want to live it? How do we want people around us to treat us? And I have a program called the 5 Wishes that I sit down and educate family members on. Because it's a difficult conversation to have with your parents, for instance, when everything's good and healthy and nobody wants to talk about it. But it's something that we all have to talk about. How do we want to live our last few days? And Michelle does a lot of speaking on hospice and end-of-life decisions and making these plans, so.
It's amazing how many people have every single penny of their finances set in stone, squared away, organized, cut and dry, done, lawyers got it covered, but haven't given a single thought to what happens if I end up on a ventilator and I can't, or do I even want to be on a ventilator? What does quality of life mean to me? And having, having these discussions with your family members, being open, and even if you need, a middle person, like Laura or myself to help facilitate that conversation, you're giving them a huge gift, because there is nothing worse than seeing 3 siblings over mom's bed when she's on a ventilator and dying. And you'll have the cardiologist come in and say, yeah, it's not looking so good today, but then the nephrologist comes in and says, no, kidneys are looking better. So but the patient is dying, clearly dying. And the family members end up split. One sibling's got one opinion, another sibling's got another opinion. It destroys what's left of the family. There's huge guilt. It's a disaster. And if you can get to the point that you can just say what you feel and think about it and give that gift to your family members, it's worth its weight.
Ahead of time.
Yes, while you're well.
Right.
While you're well, so it's not an emergent decision.
Right.
And they've heard it from you, so they don't have to make that decision.
Well, mom said she would want
she
this,
Yeah.
right?
Right, or you have no idea, because you've never had that conversation.
And I think our first seminar, we had a trust bridge here, and that was one of the big messages, that the hospice wasn't so much for the patient, it was for the family.
Right.
And, on that day, on that January event, I had a girlfriend from Atlanta. She was in town, and she's a realtor too. She said, I'm gonna come by your thing. So she came and sat in, and she heard that discussion, and when she got on the plane to leave, her cousin called and said, oh my God, Auntie so-and-so's gotta go into hospice. Oh, this is terrible, what are we gonna do? And because she'd been here, she was able to have an intelligent conversation with her, like, well, it's not that bad, here's what it's gonna be. And she called me to tell me that, and I just about cried. I'm like, okay, so what we're doing here is helping people, so that's why I keep doing it and want you to bring more people so we can outgrow this, because I want to fill an auditorium of people, because there's a lot of people in this age bracket in Palm Beach County that need to hear some of these conversations, so that when they get to the ER, they've got their meds, they know what's going on, and the doctor can better serve them and faster. Sometimes it could really be a detriment to you, and if they don't know what's going on, they're just gonna go all at it, and you might not want that, or need that, so, there's all that. Any other questions that we have? Yes, Eunice?
How about, can you talk about 6 months here and 6 months in the north? There's one company that
Does
doesn't
both.
care.
Is there one
what
company
place
who
it's
works
in. You need
in
2 different
the
places.
north and here?
There are some skilled home health agencies or out of, in multiple states. It's just, sometimes they're regional, but sometimes you can find those home health agencies. They're usually run by larger corporations, sometimes run by the hospital systems. So I've worked for both. Sometimes your care might be a little bit different, in different regions as well. But you can sometimes find those companies, but.
Okay. Anyone? Yeah?
Would anyone like to give an opinion on, what would be the best type of care for a 95-year-old mother who's very stubborn? She lives in her own home and doesn't need anything right now, but
She's 95.
but exactly, like she.
So we should have a conversation.
Right.
Care managers are pretty cool, because they can take, I'm not calling myself cool, just as a profession, we can take the pressure off family members by having frank conversations. If you think back to your school age days, there was a nurse in your school, and how many of you had a problem going to the nurse's office to tell her that, you know, you had a splinter or you hurt your foot? We just did it naturally because we trust nurses. There's a great amount of trust with a nurse, and they, for the most part, know that that nurse has their best interest in mind, and they're not gonna go blabbing their information to just anybody. And that's one of the things that I try to really focus on when I talk with my clients. I will get down at eye level, hold their hand, and promise them that I will do whatever I can to keep them safe in their home for as long as is possible. The only thing that I ask in return is that they will do shared decision-making with me. So if I make a recommendation to bring in home health, whether it's a skilled care, a private duty care, or even a practitioner coming in, that they will actually give it some thought and listen to my reasoning before they decide yes or no.
And I think that the kind of conversation she's having, and I've seen this in action with my obstinate little 88-year-old, she cracked the shell. But putting the control back into them, right? They're just trying to grasp onto everything. And so the way that Laura talks to them is helping them, putting them in the driver's seat, even using language like, now it's your decision, you're the boss here, but let's have a conversation about what I think will be good for you. You know, it's like an advocacy and just help guiding them. Because they'll just make stupid decisions all day long, you know, because that's what they think they want to do, and then they fall, and like I said at the beginning, they fall, and that could be the end of it. Who was here for the story about the woman who decided to take the painting off the wall herself, and the big painting came down and broke her clavicle, and the bone stuck out her arm? She's not going home. You know, her life just changed because she's, I'm gonna do it myself. Okay.
That'll give me something.
I have an opposite concern because I have a son who's 45 living with us who has a degenerative rare disease.
Oh, yeah.
And I wasn't sure whether or not this would be the appropriate place for me to come. And it's not cognitive, it's just physical, it's a form of muscular dystrophy.
Oh.
But I'm not sure what avenue I should go down for him. He does reside with us, and now that I've been diagnosed with something, my concern is even greater because I might not always be able to care for him.
Understood.
Sometimes something as simple as a safety evaluation of the home, the person's abilities, and any equipment that they might need. I like to use the term guardrails and safety nets. If someone has a single-story home and they have some physical disabilities, that's probably a decent home. But if they're using a walker and they can't get into the bathroom because the door isn't wide enough, then there are some adjustments that need to be made. When you have stairs in the home, that adds a whole nother level, no pun intended, of issues. Scatter rugs, whether or not smoke detectors work, whether or not someone forgets to turn the stove off, and is there equipment that can help turn the stove off if they forget. So looking at the home and the client with safety in mind is the most important thing for anyone who wants to stay in their home long term, whether they're young with disabilities or a little bit older starting to have disabilities.
And then what type of services, who would I approach to find out what type of services would be available to him, even though everything that you've mentioned we put in place for him, but.
So specific disease processes, there are many different agencies out there that can help with funding. Knowing what those resources are and the different resources available for home care is the first step. So a safety evaluation, a good safety evaluation, includes recommendations to put in place.
Oh, okay, thank you.
And is he disabled, or,
Oh, yes, he was
And
on
then-
wall.
Disability.
and you've gone through the Social Security Administration and done all that?
Yes,
Got that?
yes.
Okay,
He's on Medicare.
good. Okay.
And if there's any like acute decline, whether it be even decline more physically than what his baseline is, or even health-wise, if he develops pneumonia or some things like that, and he was in the hospital. So that would give reason for skilled home RN to come out and see him, and also therapy and stuff, develop a plan in place to get him, we always wanna bring him back to what that baseline was before, you know, he had that decline.
Well, it's degenerative, so of
Yeah.
course, you know, his baseline keeps dropping.
Yeah.
Frequently, I deal with a lot of polypharmacy too. Patients who have, 5 different specialists and a primary care that they never see. And, or they forget to tell them that their cardiologist put them on 2 new cardiac meds.
And that's my problem.
And you've got 1,000 medications. So one of the first things I do when I come in, after, we've decided we wanna work together at the meet and greet, I get the pills, the supplements, the dietary, nutritional supplements and vitamins and anything over the counter and any medication, and then we do a reconciliation. And 9 times out of 10, 5 or 6 meds are gone at first, like pretty quickly, because people go into the hospital and then they're discharged on drugs they don't need, that they never should have been discharged on. They weren't on them before they went into the hospital, and they come out, and then they're interacting with something else that they're on, so.
Well, and that's a problem, because he has specialists all over.
Right.
I mean, and I take him for everything.
Yeah.
Except he got a bed sore. And trying to figure out, put Neosporin on it, pull this one, I mean, it's like,
Yeah.
trying to get,
We should talk.
and I remember being in the hospital with my husband for 21 days during COVID. I didn't leave, because I know how important Bill Muskildum, how important advocacy is. So I stayed there, and they allowed me, because they realized that they were full.
Yeah.
But they put big, and why can't I get those? Where do I go? And those were my questions, and I really,
And that would
and
be
I have a
answers.
great
Yeah.
dermatologist, and I have a great cardiologist.
Right.
and-
Yeah,
But,
your skilled therapist and skilled nursing coming into the home could,
no,
they should be able to make those recommendations for those equipment things for that, teaching you body position and to prevent any future
And
bed
that's
sores. And
what
then
we
also
really
that
need.
equipment, those booties and things like that, the type of
Oh,
mattress
yeah.
he has, all the type of things that, those home clinicians can make those recommendations for him. And also Medicare does pay for maintenance therapy with diagnoses like your son's and degenerative and long, ongoing, they pay for, a therapist to come out, and maintain, it's called maintenance therapy.
and his neurologist gave him a script for physical therapy. He's very independent, he works out every day, as difficult as it is for him, so he's able to transfer. So he's as independent as anyone could be with his disability. And of course, he's male, so he's a little stubborn about it as well. But he, no offense to the gentleman. But, it's still difficult, yeah. But that would be, but he does have a script for physical therapy, but getting him to a physical therapist.
So for
Should say
him,
home health.
it's definitely, right, extra burden for him to get outside of the home to go to outpatient, so he should qualify for home health care.
Right, and I should speak to you about it.
In-home.
Yeah, it should say home health, physical, home health
You
for
can get the order changed.
skilled
Yeah.
nursing.
So it says,
Yeah.
Oh, I could do that, yeah.
It's just verbiage on
It
the
is.
script that needs to change.
A question for Laura on a safety evaluation, is there a base charge or, does it vary?
Well, that's like organization last meeting, that's what they do, they come
Yes,
in
the occupational
and they
therapist,
just
Allison.
look at your house
So
and
I
make
wanna know what she
recommendations.
charges, what the fee is.
She's private.
Yeah, so she can
Yeah.
talk with you.
So for care management services, it is private pay, and we can talk about the evaluation. It really depends on a few things. If there are a lot of medical diagnoses and medications, it will take a little bit longer.
No, just preventative for
Yeah.
myself,
Okay.
because I'm not yet ready, but I probably will be.
Okay. Usually that takes me a couple of hours, and the base price or fee that I charge for that is about $250.
Okay, good to know. Okay,
And
thank you.
Lisa, you had a question.
I also have a daughter who's multiply disabled and lived at home, in Massachusetts for many, many years, and received personal care assistance services, but Medicaid paid for all of that. And, because she's a disabled adult. So I was wondering, do any of your agencies work with Medicaid at all? Or do you have to go to a different agency to get Medicaid services? If I were to bring her here to Florida?
Pinnacle, personally, we do not accept Medicaid. There are other agencies that we could refer you to that does accept Medicaid.
We do not work with Medicaid. Florida does have some Medicaid programs. My suggestion would be contacting the Area Agency on Aging, who can give you all the information about those programs.
Thank you.
Yeah, I do not accept Medicaid either, unfortunately. No.
But does this person not have Medicare?
She also
and
has Medicare,
Med-
yes.
So in that
Yeah.
option,
It's
we
not
would bill,
secondary,
we bill them, we can bill the Medicare, not the
Yeah.
Medicaid, right?
Okay. What else do you wanna know? All right, well, we have a big, it's Mary Beth's birthday today. So,
Yeah.
Look at that.
Somebody.
Yeah.
you know what, it's on the back